Good afternoon, everyone. Uh, we have a little thin audience for the very simple reason that thanks to the plenary session, which really was good, people have just gone for lunch and they've opened the lunch now, so we can expect the crowd to come in a little later. But our podium is full, which is the most important thing. Having said that, I'm going to start off first by managing dislocated lenses, and we'll see how it gets on from there. I'm going to first start off with something a little different. This is known as trans-iridial suturing of a lens. It is something which you will find interesting, and I'm sure you will try and do it because it makes life very easy. It's a sclerocorneal trans-iridial secondarily sutured IOL. It utilizes quite a different system and a different way of handling it. Let me take you down. A quick short animation to explain you exactly how this works. As you can see on top, you see the implant there, and you notice the two little switches in the side which go through the iris and out, through a little groove on the sclera, through which ultimately the switches are going to be locked into place. So the whole idea behind this procedure is that you no longer have to worry about where your buried switches are going to be, and you no longer have to worry about how to pull the loops out, pull the switches in and handle it. It's just a very simple way of doing it. The day you're feeling lazy, this is the easy way. All you have to do is make a small incision on the conjunctiva. Nothing great, nothing very sophisticated. Open it a little at the side, a little cautery to get rid of the excess bleeding which is there. And then the next step, I utilize a diamond knife, but you can utilize a metal blade if you wish, basically set at 50 microns. And you utilize this and you make a little cut on the scleral side of the cornea, a horizontal cut, just at the edge of the cornea scleral junction. It may look funny to you, but be with me because you'll find it interesting. Once you do that, the next step which you need to do is to utilize your Prolene 10-0 nylon, put it through the iris, pull it out the other side and railroad it, utilizing another needle from the opposite side. Usually we use a 25 gauge and you can railroad it easily with that. Once your suture has been passed through, the next step, of course, is simple. You pull the suture out. And having pulled the suture out, you attach it onto your implant. The procedure is not complicated. It makes life simple. This is just a simple way of handling everything. Suture it onto your edges of your loops, and having done that, you can then just simply place your IOL inside the bag. You can utilize any lens you wish. It doesn't really matter. That's not really important. This is a Rayner I'm using. And having done that, you put the lens in, or push the lens in. A Rayner lens is flexible, so it goes in comfortably through a 4mm incision, a 4.5mm incision. Just have to push the lens a little, and as you will notice, the lens folds by itself. So you don't really have to open the incision too much. You need to widen it a little because I use it normally at 2.2 when I do my phaco work, and then you introduce your lens in. Push it, the lens will fold itself, something people don't often realize. Once it goes in, that's simple, you put the lenses in. Now comes the interesting part, and the basis of this entire talk which I'm talking to you about is how that loops are now sutured. You pull your loops on both sides until you get the lens to center properly. And then taking the loops and taking the needle, the important step is that you are going to go through the length of the incision. That's very important. You remember the incision which you made? Now go through the length of the incision coming to the opposite side. So essentially the suture is tracking a little deeper than 40 microns. And you suture it at that place there. So your suture essentially is buried in the scleral incision which you have made. You no longer then have to worry about the suture, whether it will come out, whether it will be there, and what are you going to do with it. Once again, the same thing. You bury it along the length of the incision which you have made. Burying it along the length of the incision means that you no longer have to be worried about the suture not coming out, no longer worried about the conjunctiva being exposed, being knots coming out on the outer side. It just automatically works its way in. So this is a simple way of handling this procedure. As you've gone through the iris, you've taken the lens, and you have just sutured it on. Just nick the things, and then you don't have to worry too much about the conjunctiva. Just pull it together and hold it in place. If you want, you can glue it, but not really required. So conjunctiva adheres to itself without too much of a problem. Let me now go on to something else. I'm going to take you on to what is called the proline fixation method, something which has worked well. It utilizes two sutures along the lens, and we have tried to modify it so that the two ends become the standard norm for fixing a secondary IOL. I'm happy that Sri Ganesh is with us because it is from him that I learned the procedure in the first place. So I should really call it the Ganesh Yamane modification of subluxated lens. Now this is a subluxated lens. As you will notice, the movement of the bag and the lens, everything is nice and shaky. You know that there's really nothing much left over. You try any funny stunts and everything is going to go down. And your retina man is going to be very happy that you gave him a new case. All you have to do again is lift your subconjunctiva on both sides, and of course remove the bag. The whole thing is totally light, so there's really nothing much you're going to do. You're not going to be able to stabilize it in any way. You mark 3 millimeters on both sides like a little square. Something which I learned from Amar, the way he was doing his. So, you learn a little from everyone. And now at this place, what you do is first put in your AC maintainer. Having done that, you take two 25 gauge needles and track them horizontally to make two tunnels, just horizontal tunnels, what we call the Yamane tunnels. Track them and then do nothing more after that. You remove the IOL, which comes out. You notice that half the bag is hanging out here. Because your fluid is being fed in at the same time, you get a little prolapse, which you stop the fluid and it automatically goes in. This is the bag. An air bubble you insert. And put a single cross stitch. I belong to the old school. I don't like leaving eyes open at any time. Patient coughs, you get in problems. You put in a single cross stitch to make sure it remains shut. So nothing more needs to be done at that stage. And the next step you would utilize is your proline. This is 50 proline. You just cut it and use it. And the proline is fed into a needle, into a 27 gauge needle. Leaving just a little loop outside, and you feed it in from the side. Remember that the tunnels you made, you now go horizontal and then go vertical. So it's like a self-sealing tunnel. And you hold the loop and you take it out. make sure the loops don't cross. That's the most important thing, otherwise you'll end up in problems in the end. Do the same thing on both sides. Take your next step is simple. You take your lens, put it on a rubber bung. Actually, this is the side bung of the Zeiss one, and put a needle through it. Now the needles are also two 27 gauge needles, empty. When you lift them off the rubber bung, the lens is lifted off with it naturally. Now in this, the same needles which in the same loop Prolene which you pulled out, you now feed in. This is just a way makes life a little easy. Feed the Prolene which you had taken last time out. And now, having done that, your lens comes there, you push the lens out, which you got stuck onto the, and then you utilize a thermal cautery. It's a low heat cautery which we utilize to cause a little bump, as one would say, which acts as a sealant and also causes a little area of hardness so that the lens is there. Be sure to pull and make sure that it is properly secured. Next step, of course, is simple. You insert the lens in the eye. And having inserted the lens in the eye, pull the tractional sutures on both sides so that the lens stabilizes well, and close the wound up. As I said, old-fashioned, I close all wound sessions. I don't like leaving anything open. A single cross-stitch is usually, or a double cross-stitch is usually enough. And now you've got the loops lying at the end. You center your lens properly. And use your thermal cautery to create a little ball on both sides. Then use a conjunctiva and cover up the tail. It's a great procedure. Then most important thing is, of course, do a vitrectomy, anterior vitrectomy. Do with a little steroid to make sure that it is perfect, that there's no residual vitreous anywhere there. And use a coaptation cautery to close the conjunctiva. And that is it. That's the simple, straightforward way. Thank you for watching. We are now invite our next speaker, Dr. Sri Ganesh. He is a prominent figure in ophthalmology, chairman and managing director at Netradama Hospitals Private Limited, an exceptional surgeon, as I'm sure you will now notice. On to you, Ganesh.
Hello. Thank you, Dr. Keki, and for inviting me to this IC. And I'll present some of the newer techniques of scleral fixation, which is the modified 4-flange technique. So optical rehabilitation in patients with aphakia presents a very unique challenge, and choice of the IOL implantation in the presence of little or no capsular support includes an antechamber lens, an iris fixated IOL, and a scleral fixated IOL. Each of these techniques has its own merits and demerits, so let's look at them. The ACIOL can cause potential damage to the corneal endothelium and angle structures, and by and large has kind of become obsolete. The iris fixated IOL, like retrofixation of the claw lenses, are quite popular. It's easy to do, but you can have pigment release and inflammation. The scleral fixated IOL has the advantage of a more physiological position near the nodal point of the eye and the greatest distance from the cornea, so it is more friendly to the endothelium. So sutured scleral fixated IOLs have been the traditional way of fixating IOLs, but there can be quite a few complications, including suture erosion, breakage, what is known as the yo-yo syndrome, lens dislocation, etc. Quite a few complications, and this is mainly done by the retina surgeons, posterior segment surgeons. Professor Amar Agarwal introduced the glued IOL technique, and it has become quite popular where you make scleral flaps. But again, you need some amount of surgical expertise and then the handshake technique. You can have some complications like scleral flap issues or haptic extrusion or haptic breakage. Then you have the M&A technique. Again, this is a popular technique but has its own challenges, like it is technically challenging to do. You can have a higher incidence of IOL decentration, tilt, pupil capture of the IOL can be a problem, and vitreous hemorrhage. Canabrava described the four-flange technique. Again, it's becoming popular because of its simplicity. You need calipers, 27 gauge needles, 6/0 polypropylene sutures. The IOL is a PMMA IOL with eyelets and a thermal cautery. And in this technique, basically what he does is he introduces a 26 gauge needle and railroads the proline inside the eye and then pulls it out. That is done on either side, diametrically opposite each other. And in what we did was we modified the four-flange technique. So you cut out two pieces of 6/0 proline, approximately 5 centimeters, pre-thread it into a 27 gauge needle, so that even if there is any corneal opacity or so you can still do it. It's almost, you don't have to visualize. You're not doing many things inside the eye. Just gently push the proline so it extrudes through the needle, and then you can just pull it out through a microforceps. And this makes it much easier, and you don't have to have so much of dexterity to railroad the proline. Once you pull it out, you just put it through the eyelets of the PMMA and use a thermal cautery to create the flange. Put the IOL in, pull on the proline sutures so that it's tight, and then cauterize and flange the external proline, and then you have a nice secondary IOL. These are some of the challenging cases. This was a case of trauma, aniridia, where retinal detachment surgery and corneal grafting, a tectonic graft was done, and it was aphakic. A bad road traffic accident. Here we planned an aniridia IOL. So there's the same technique where we preload the proline, pull it out. I've released some of the sutures, and this is a very large lens. So you put in the proline through the eyelet. You have to see that the flange is on the posterior aspect. The direction is very important. Similar kind of flange is done on the other side, and then the lens is actually put in. Here, of course, there is no vitreous because vitrectomy has been done, but some of the peripheral, little bit of peripheral strands we kind of, and then remove the sutures, because again here we have to do a regraft because this was just a therapeutic graft, has to be exchanged for an optical graft. So put in the lens and then pull on the sutures so that the IOL centers well, hold it, cut, and then cauterize. So it's actually quite simple to do, and even my fellows are able to pick up this technique. Just pull the conjunctiva so you don't have to reflect the conjunctiva, and then this graft was kind of exchanged for an optical graft. And then the new graft was placed, and that is the end of the procedure. So I will show you the post-op pictures. This was how it was looking day one. So this is a fixation of the aniridia lens combined with a corneal graft. And this patient did quite well. Another interesting case was a Marfan syndrome. Now this patient was a 14-year-old with severe subluxated lens and had also corneal astigmatism of about 2.5 diopters. So ideally a toric lens should be used. Now I have developed what is known as a swivel haptic IOL. So we decided to use the foldable swivel haptic IOL because you can't open the incision and you don't get torics in PMMA. So let me show you the technique. So here, that is the Callisto. I just put in a trocar cannula for infusion. Then I go in and then I just do a lensectomy. I just aspirate the soft lens material. So I do a capsulorhexis. I don't like fixating the bag because this is progressive. It's a progressive condition where you can have progressive subluxation. I just use the IA to remove the lens matter, then just remove the entire capsular bag with the microforceps. And now you have aphakia, you can do a vitrectomy, anterovitrectomy, and this is the swivel haptic IOL. The swivels have holes in the edges, so you can actually load the lens into any cartridge. You put it in front of the iris, and then you're using the 4-flange technique to fixate the swivel. So that is how the 6-4-Prolene is passed through the eyelet of the swivel haptic and cauterized. This is a toric lens, so you can see that you have to be exactly 90 degrees from the axis and do the entry with the needle. That's the flanging being done on the other side. And when you actually pull on the lens, pull on the Prolene sutures, you can see that it is on axis. The external cauterization is done for the flanging, and the conjunctiva is closed. This is the end of the procedure. You can see that the lens is fairly on axis, and this patient did quite well with an uncorrected vision of 6/9. So these are a few of the interesting cases. In our experience, we just looked at a retrospective case series of 52 eyes, mean age of 65 years. We had a follow-up of 1.5 years, and these were the indications, which included introp PCR, introp ZD, trauma Marfan syndrome, subluxated IOL, dislocated IOL, where we used the 4-flange technique. And these were the visual and refractive outcomes, which was fairly good. You can see that the corrected distance visual acuity was around on average 0.25 logmar. The residual sphere was 0.28, so fairly good refractive result. Of course, PMMA lenses being used, we had some amount of astigmatism. And the IOP was normal over the follow-up period. These are a few of the clinical pictures, day 1, 6 months. And we also did the UBM, and you can see that the lens placement is very nice with no tilt or decentration. We had actually few introp complications, one haptic slippage, one introp IOL tilt, one haptic breakage. Otherwise, 49 of the eyes were all normal. Again, you can avoid these. This was in the early cases. So you shouldn't leave the suture loose. You have to actually pull it and then cauterize it so it's flush against the sclera. So there is no movement. We had flange exposure in one case because of a loose suture. We again revised that and it was normal. IOL tilt in 2 cases and hypotony. And this is the kind of revision. So you always have to see that you flange it properly and cover it with conjunctiva. And when you flange it, don't touch the Prolene. Otherwise, it becomes rough and there's a higher risk of erosion. It has to be smooth on the surface. So the 4-flange technique of SFIL is safe and effective, relatively easy to perform, useful in hazy corneas, short learning curve. Thank you very much, and I invite you all for the 37th APSARS in August in Ahmedabad.
Thank you, Sri. As everyone knows about Sri being such an excellent surgeon, the next speaker is another great surgeon, Mahipal from Center for Sight. And Mahipal will talk to us on the way he manages his cases.
Thank you very much. I'll be talking about subluxated cataract, and I'll be talking specifically as to how we manage it using the femtolaser assisted cataract surgery. Now, as has been said by the earlier speakers, in subluxated cataract, what is the basic aim? The basic aim in this is to preserve the capsular bag, and to have minimal vitreous loss, because if you have vitreous loss, it's very difficult to keep the bag in place. And if you have the bag preserved with minimal vitreous loss, you will be able to place the IOL properly, and this would reduce the risk of problems like retinal detachment, glaucoma, iris chafing, etc. Now, what is important is that when you are doing a subluxated cataract, there is the importance of having a clinical assessment so that you are prepared beforehand. And obviously, these are the sign phacodonosis. There is an increase in the intralenticular space. There could be a lens edge that could be seen. And you should also assess in the supine position. Sometimes the patient comes and you don't find it at that time, but on the table you see that. Now, these are the various reasons that obviously you are aware of as to why there could be subluxation, trauma being one of the important things. Now, once you have assessed that there is a subluxation, what you have to do is that you have to assess the extent of subluxation, like to find out what is the etiology of subluxation, because this can define whether it is likely to progress or it's going to be stationary subluxation. And also you have to assess the grade of the cataract. If you assess the grade of the cataract, that can help you plan the surgery. Now, this is normally the dictum that I follow, that if it is a small subluxation less than 3 clock hours, you could either use the 3-piece haptics, not a single piece, but the 3-piece haptics, align it in such a way that there is a pressure on where the subluxation is so that you get a taut capsule, or you just use a CTR. If it is still more, then you possibly would need to do a ring fixation if a CTR is not working. And more than that, if and it's a progressive disease, then you have to definitely go in for the glued IOL, whether the technique as Amar proposed or what you have the Yamane technique, etc. I normally in large subluxations prefer to do the glued IOL. Now, the challenges obviously are that if the subluxation is more, there is the problem of having an intact capsular axis, and that is crucial for you to have. There is an excess in the lens mobility, lens tilt is there, and displacement, and if there is vitreous in the anterior chamber, that makes doing a capsular axis difficult, because there isn't a traction or a counter traction force that you have. If you have a discontinuity in the capsular axis rim, putting in a CTR becomes a relative contraindication, because it will rip it apart and it is going to increase, and you may lose the CTR into the vitreous. The other problem is, because there is a subluxation, you have a space, so there could be a continuous vitreous hydration that happens during phacoemulsification, and this makes the whole thing worse, because the vitreous keeps on coming out, and this leads to more vitreous positive pressure and shallowing of the anterior chamber. So, can we make it easier? So, these are two techniques that I am going to talk about. One is the FLACS, the femtolaser assisted cataract, and the second is a vitreous decompensation, which is there. This is a video loaned to me by Dr. Kumar. This was a small pupil, irregular shallow AC. You can see there is a iridotomy that has been done. You can see, I'll just show you, this is a subluxation. Can you see the phacodonosis? You can see this is phacodonosis in this case. It's a shallow AC. What do you do in this particular case? So basically, go ahead, put a Malugan ring in this particular case. Once the Malugan ring, can you see the subluxation? You see the iris bowing? And this is obviously a bad iris, that is, there is a bad subluxation, there is a phacodonosis as was seen, and you can center the capsular axis, make it larger, and once you have centered, you just press on the catalyst system, and you can see that you get a good capsular axis. That is the biggest advantage that you have with the femto, that irrespective of the subluxation, because it has an OCT image, it will get you a good capsular axis, irrespective of the fact if there is vitreous in the AC, it is still going to get you a good capsular axis, and that is going to be like half the battle won. So, once you have done this particular thing, you have got the nucleotomy also done, then you go ahead and do the procedure which is there. Now, let's look at the advantages that you have on the femto-assisted cataract surgery. It is not dependent on Zoller counter traction for capsular axis, and is done in a closed chamber and allows lens fragmentation without any additional stress. Well, this is the, after the femto, because you have been able to do the capsulorhexis well, the ring is in place. You can see that there is mobility of the nucleus. So what is being used is the hooks. Ideally, capsular hooks should be used, but these are the iris hooks which can still stabilize. And once you have stabilized, so you have a Malugin ring, you have capsular hooks, and you can work and get away the pre-chopped nucleus, as you can see. And there is a second capsular hook that has been an iris hook used as a capsular hook which is there. Once you have done that, you can see that the procedure of surgery becomes relatively easier. You have a stable bag, you have a good capsulorhexis, you have to do a slow motion phacoemulsification. Bimanual IA is therefore recommended. Now putting in a capsular tension ring to get the entire thing in position so that it remains in position. And once you have done that, you put an intraocular lens. So this is something where a femto laser is obviously going to be helpful. Now this is another case of a traumatic subluxation. You can see whenever I have subluxations, I push the patient towards, towards femto. Can you see the crumpling of the iris? Can you see the vitreous here? So this is a condition you have to get onto the pupil because there could be falsification. We are just raising the lower end of the femto posterior capsule so that there isn't any problem in that. Once you have that, you can see that we have done a capsulotomy and a good capsulorhexis. Now see, there is this traumatic case. You could, this is the iris atrophy. He had a shuttlecock injury. Can you see this subluxation? Can you see the vitreous coming out here? Advantage again is that you get a great capsulorhexis. Once you have a great capsulorhexis, your half the battle is won. This is the capsular hooks that we are putting in this particular case. You can see this is capsular hook again, gentle hydrodissection which is done, pre-chopped nucleus, so you are able to have a good nucleotomy with the femto, and again slow motion phaco, you are able to remove the pieces of the nucleus, putting in a CTR. You don't need to do, because this is less than 6 clock hours, you don't need to put in a fixation with a suture. A CTR will hold, and now you can again see this is a 3-piece lens that we have. It will again give you more stability. Just putting in tricot, the vitreous which was there right from the beginning, doing a vitrectomy. Once the vitrectomy is done, we go ahead and do SFT again. Amar has kind of described that. Once you have this SFT that is there, you can go ahead and close it. And this patient is doing well. Actually, day one, the patient had a 6/9 vision. Just to see that the vitreous is not there, just put an air bubble. This is the final thing. This is vitreous decompression. So you use the pars plana side to decompress the vitreous, because the hydration of the vitreous causes a problem. Intermittent vitrectomy with moderate cutting and low vacuum is something that is required. So again, you see this is a subluxated cataract. There is vitreous post subluxation. This is 6/9. He was a doctor who came to me from Patna. Phacodonosis, grade 3 cataract. Let's do a femto assisted cataract surgery in this particular case. Again, you can see, I'll just go forward. Again, can you see this vitreous here? This is the vitreous blob. You can see that the iris is falling back. You have to look at both the anterior and the posterior capsule. You can change the widgets, and you can get it onto the anterior and the posterior capsule. Capsulotomy, you can center. So I'm on the scanned capsule, but you can see it's going on the side. The modifications required because it is cutting onto the iris. So we're making it small, but you can see it's still cutting the iris. So what we do is that we move it slightly. See, actually, when you're doing a scanned capsulorhexis, if you have put the ring, the thing is going to move towards a different part. So you really want, so you can see now I am just, this is, so you have a custom center also that you can do. One is scanned capsule, limbal scanned, you can have pupil center, so you can have all these. This is the femto procedure that has been done. Once you have the femto procedure that is done, just see here we are doing the pars plana approach. Here again there is vitreous. We are taking away the fluid from the side. We have done the trocar cannula. You can see this is a vitrectomy. We have put tricot. You see the lens moving towards that area. The capsulotomy again is free flowing. That again, as to re-emphasize, femto gives you a free floating capsulotomy or a good capsulotomy irrespective of the amount of subluxation that is there. I'm putting a ring now. Once the ring has been put right in the beginning, you can see that again a pre-chopped nucleus, easy to get it out. And once the nucleus is out, you can go ahead, bimanual irrigation aspiration, keep the chamber deep. Once it is deep, go in with a 3-piece intraocular lens and again go back, do a vitrectomy. So a pars plana approach is also very important, or is a good technique when I feel that the subluxation is too large. Then I want my retina people to help me and do a 3-port availability at that time so that we can have a vitreous decomposition along with it. And then once you cut away the vitreous tags which were there, and that is the end of the surgery, and this is the post-op view of this particular case. So this is what we have. This is Journal of Cataract Surgery. We call it as limited pars plana vitrectomy to optimize the surgical outcomes in subluxated cataracts doing femtolaser. So my choice is a femtolaser assisted cataract surgery in cases who have subluxation, even if they have some amount of vitreous that is coming in, and usually the results are good. The advantages of this vitreous decompensation is that it prevents further herniation into the anterior chamber, deepens the anterior chamber, creates the adequate space for you to do phacoemulsification, and you use these capsular expansion and fixation devices to keep the whole thing there. So the take-home message in this is that you need to have low fluid settings to prevent surge, tamponade the area of zonular defect with dispersive viscoelastic, do femtolaser assisted capsulotomy, and vitreous decompensation through the pars plana route will allow you to do safe phacoemulsification. So friends, difficult situations often yield the best results if you are able to apply technology and the little adaptations of a capsular hook, CTR, or fixation, etc. So that was what I wanted to bring home to you, that femto is a powerful tool for these cases of subluxation. Thank you very much for your kind attention. Thank you.
Any questions anybody would like to say? So I think what Mahipal has said, that femto really does assist in complicated cases and tough cases where it does make your life much easier. So I mean, to do a rhexis in a subluxated case and always get it right, and then you can go ahead and put your hooks and further save the case. So I think that no doubt is a right route to take. Now I invite none other than the Amar Agarwal of Indian ophthalmology. So I call him the Amitabh of ophthalmology, who has innovated so much that it helps in our day-to-day surgery. Over to Amar.
Thank you very much, Kumar, and I'd like to thank also Keki for this invitation. So let's look at this first patient. This came to me from Bombay, and you can see this subluxed iris claw IOL. So you see that patient, not from your hospital.
I take back all my words.
Not from your hospital. The patient can't come from Kumar's hospital. So you see, anyway, this patient, no chance. How can he compete with Suhas? So you see, now I've done 2 flaps there, and you notice it's dangling that IOL there. Now I fixed infusion inside the eye. I know this is an iris claw IOL. So I'm making a scleral tunnel. Now after the vitrectomy, you can see there, the lens is half sinking. So catch it, and you see the problem here is, half of this IOL is still stuck to the iris. The other haptic has dislodged. This can happen with the iris claw lenses. Slowly I've dislodged it, but you notice there is an iridiolysis also present. Since it's a larger lens, we need to explant it with a scleral tunnel incision. I prefer to do that rather than making a clear corneal incision. I've done the handshake technique, as you can see, and pulled it out. So that's the iris claw IOL which has come out. Now we go in with the glued IOL. You can implant the IOL just like a non-foldable, because I already have a large incision. So one haptic is out. Now we can push the other haptic inside. You can do the no assistant technique, and then do the handshake technique. Go inside, transfer the haptic from one hand to the other, catch the tip of the haptic. Once the tip of the haptic is caught, pull it out. So far, so good. Now watch the amount of haptic externalize, it's a lot. So now you create the Chariot's pocket with the 26 gauge needle. Once both haptics are tucked, then we know we are comparatively safe. So here you can see both haptics gone inside the pocket there. Now the problem is this iodialysis. So how do you fix an iodialysis? Right opposite it, you fix the trocar. This is an Alcon's 25 gauge trocar. You see it's blue in color. So you can use a 25 gauge trocar, then take a double armed Prolene needle. This is the trocar assisted iodialysis repair. Pass it through the iris, it comes out through the sclera. Now you take the second arm of the double arm needle, again pass through the iris, comes out through the sclera. All you need to do is pull. Look, I'm pulling it, and when you pull it, the iris will get repaired, the iodialysis. Suture it. Now, remember one thing. Once you have done that, please understand the iris has gone pulled to one side. So now what happens is, I now do the fourth row pupilloplasty. So this is a two-fold technique. Please understand. You combine a trocar-assisted iodialysis with the single pass fourth row pupilloplasty. And this is the two-fold technique. Now you see the difference. That iris which is pulled to the one side gets repaired. Now you can do as many times as you want the single pass, fourth row, pupilloplasty as you want. The key point is the Purkinje image P1. So watch that Purkinje image P1 has to be bang centered. Here you see I brought the loop out. Once that is out, 4 times you've done it. Now you look at the Purkinje image there, and that's P1. Don't concentrate on the reverse inverted one. Look at the inverted one. That's P4. Focus on the P1 only. Once you have done that, I would like to make it slightly smaller here to make it more like a pinhole, because I know this patient otherwise will have a bit of an astigmatic effect also coming into the picture there. So I'm just doing some more fourth row pupilloplasty. The advantage in fourth row is you can do it as many times as you want till you want to make the pupil as much as you want. If you're targeting a 1.5 millimeter pupil, you look at approximately 2-3 times to do on either side. Now I use the vitrectomy probe to just check my pupil is bang centered onto the Purkinje image. And look at that. It's right on track. Apply the glue, seal everything down there. Once that's done, the glue also seals the conjunctiva, and that completes this particular case of subluxed iris claw IOL. So you can see now this is how the patient intraoperative picture was. So you can see pre-op, you can see the intraop, post-op day 3. Sorry, this was from Ghana. So not from Bombay, Kumar. And that completes this particular case. Now we look at another case which I thought I'll show you. This is called triple trouble, okay? Now again in this case, what has happened is the patient had endothelial decompensation, one piece foldable IOL the surgeon had implanted, and there's a nucleus piece inside, and the IOL is obviously a one piece which has to come out. But the problem here is there's also bullous keratopathy. So the first step I'm doing is now I'm just taking out the epithelium. This is another thing which I would suggest everyone to move into. It's a 25 gauge trocar AC maintainer. The same thing you can do is an Alcon, but look at it. The cannula is going above the iris, not behind the iris. So it makes it very, very safe if you're an anterior segment surgeon. So I suggest people to move to the trocar AC maintainer. Now I'm trying to bring that nucleus anteriorly. Once my lens matter is brought anteriorly, you bring it above the IOL. You can see there, the retina I went and checked also, the fragment is there. Now I'm using the scaffold technique. So I'm not explanting that one piece foldable IOL because I'm using it like a scaffold. Now once that's done, I have to obviously explant the one piece foldable IOL. I can't leave that behind in the sulcus. So now I've done this sclerotomy. Please remember, don't go too far back. Go as close as you can. And that is why sometimes I do an iridectomy in the iris. Now once that's done, I then go in, and now what I'm going to do is, after the vitrectomy, you can see, I'm now going to implant a 3-piece IOL. But look, I have not explanted the foldable IOL. I'm implanting the 3-piece IOL, and once that's inside, I will externalize the first haptic. Once the first haptic comes out, you will see me externalizing the second with a handshake technique. So please understand, Again, you use the no assistant technique and then follow it with the handshake technique to get the both haptics out. Once that's done, see the amount of haptic exercise is a lot. Now what have I done? I have done a glued IOL which will work like a scaffold for the cutting and bisecting of the one piece foldable IOL. Now I have no fear of this foldable IOL going down because the IOL which is there, the glued IOL, is like a posterior capsule. At this stage now, I was quite happy, and you can see now I'm going to now remove the iris hooks, and to my dismay, before that you can see that white structure forming there, and that scared me because I saw a white mass there forming, and I knew I'm in trouble. So I went inside and saw, I realized obviously there's a choroidal detachment which has formed in the patient. Now I have a choice: one, close up the case as fast as possible, and you can see the choroidal there. I've gone inside to do a vitrectomy to see what's going on inside. I thought, let me go fast and see if I can complete this case rather than abandoning the case. So I thought I have to first do the fourth row pupillasty. Those who have not done it, simple way, pass from the clear cornea through iris. From the other side, go in through a 30 gauge needle or a 26 gauge needle, railroad the two, bring it out. Now, this is the single pass. Once this is out, you'll see here, I'll go inside and catch this and bring it out. I have to give credit to Dr. Priya Narang also for this and the other techniques which she has helped us in. There you can see that fourth row pupillasty done. Once that's done, I will just do one more on the other side here to make it a bit smaller. Remember, there's a choroidal detachment behind, so my heart is sinking already. So now I continue to do this, but remember I have to end this with a PDEC also. So I create the bubble here. Why do we do PDEC and not DSEX or DMEX is because in PDEX, we are using only young donors. It's very easy to manipulate. You don't get a detachment or a rebubbling. By and large, the rebubbling rate is less than 3%. So I take out the endothelium. I've shifted the fluid, which is in the anterior chamber, to air. So now what's happening is continuous air is flowing inside the eye. I take the PDEC graft, inject it inside. Once I've injected, I'll unroll it. Once you have unrolled it, then I'll on the air back again and fix the graft totally. Once that is done, you will see how the case looks when it's completed there. So that's with the glue there. We have sealed it down there. That's post-op day 1. Okay. Now let's look at the patient 1 month post-op, 6-9. But remember, the patient had that choroidal detachment. This is 1 month post-op fundus. Remember this patient now, this was intraop after the nucleus removal. I showed it to you. It is absolutely good. But I created a mess somewhere, and I created the choroidal detachment. And that's what will give you a big advantage of the trocar AC maintainer, because the trocar AC maintainer helped me a lot. If I had a pars plana trocar, I tell you what, I would have been a bigger mess than what I was. And post-op, 1 month, you can see the final picture there. I'll just close up with one last case, which I thought I'll just show you in a second. This had come to me from Haryana, and why I'm trying to show you this clip is, this was a big shot VIP patient who had come to me from Haryana, in which there was a large white to white. So I did a vertical flap. Once you have done a vertical flap, remember, you have to sit exactly 90 degrees from that. So that's the correct shake for the handshake. And what I want to show you here in this case is, look at this peripheral iridectomy. Those who are doing glued IOL, I suggest do this. The advantage of the peripheral iridectomy is, then when I do a sclerotomy, I'll come more anterior. Again, you can see I've got a trocar AC maintainer fixed, and you can see there, I've done this sclerotomy. I'm able to come more anteriorly without damaging the iris. And once you do that, what will happen is, you'll get more haptic externalized. Pupil is not dilated, and what I want to show you here is, the surgeon had put a 3-piece multifocal IOL. So now, after some vitrectomy, what I'm going to do is I'm going to make the same IOL, fix it. Actually, Kumar had won a Best Film Festival award in a beautiful video which he made for the ASCRS on this technique, showing the same lenses being fixed also. So here you can see I'm doing the handshake technique. Catch the haptic anywhere. Doesn't matter where you catch it. Okay? Wherever you catch it, now transfer the haptic from one hand to the other, And you see me doing that just now. Till you catch the tip of the haptic. Once the tip of the haptic is caught, catch, pull it out. So far, so good. Same thing now you'll do in the other hand. So what you do now is, once one haptic is through, then life becomes very easy. Catch the haptic anywhere. Again, see, you need 2 forceps. Any company will give you these forceps. Epsilon are there. There are dime a dozen companies having this. Now you see my second haptic is out. Now look carefully at the amount of haptic externalized. It's a lot. So this patient's IOL, when tucked inside, will not sublux. Now once you have tucked the haptic, look at the optic capture, because when you come anteriorly, remember one problem. When you come anteriorly, you can get an optic capture, and that's there. So all you need to do is end it with the 4th row pupilleplasty and close this case. So here you see the last photographs which I'm going to show you is I'm creating the Chariot's tunnel with a 26 gauge needle, creating this tuck. Then once that's done, and once that's done, I'll now move into the 4th row pupilleplasty, which I just showed you about. And this optic capture which you are seeing will get solved in a second. So here you can see I'm doing the 4th row pupilleplasty once again and closing it. I'll close this case right now so that we can ask others to come and speak. Thank you very much.
That was fantastic, Amar. I mean, besides the 4th row pupilloplasty that you made so simple, before that, you know, all of us were struggling with doing this technique, but once you showed this, we all started it, and it's made, I think, everybody's life really very easy. I invite the next speaker. Any questions for Amar? Please ask. Invite next speaker, who is also one of the most brilliant surgeons that we have in the country, Dr. Tanvi Haldipurkar. As the name suggests, she's the daughter of Dr. Suhas Haldipurkar, but she has huge volume, and they have an excellent team doing brilliant work. Yeah.
Hi. Thank you so much for the introduction, sir. Because of courageous surgeons like you, Dr. Agarwal, sir, and so many others, I think we've got a fair idea of how to deal with things when they come to us. So today I'm going to talk about managing post-traumatic dislocated lens back complex. One would think that traumatic dislocation is something only a super specialized surgeon may have to encounter, but I think that's changing, and it could be a trivial trauma or just a hard blow, but for some reason or the other, we've been getting a lot of these cases coming to us. So let's try and understand what exactly is happening. So we know that there is a blunt force that gets applied on mainly the anteroposterior direction on the eye, and this leads to an equatorial expansion, which will cause the zonules, the zonular fibers, which are inelastic, to kind of disrupt, and that in the end lands up dislocating the lens back, which could either be anteriorly or into the posterior segment. These zonular fibers are tiny, they are thread-like, inelastic structures which connect the lens to the ciliary body, and their strength is obviously crucial for maintaining the lens stability as well as accommodation. Now, when I was trying to understand whether could there be something we can do in the primary setting, because there are patients who have pseudoexfoliation, Marfan syndrome, or they just present to us with an initial subluxated cataract, and can we do something to them in the initial visit which could help them later in the past? And we used to use a lot of CTRs, and this study kind of made me rethink, because they did a series, or they looked at a series of 23 cases almost, and they found it that in the long term, whether you use CTR or not, there is going to be subluxation after 6 to 8 years. So I think that now the understanding is that along with the CTR, maybe you need to fix the bag externally to the sclera somehow, or in any other way, which requires an additional support, because otherwise be prepared in the next 8 years to do a refixation. So we saw in the initial talks about how the patient may present to you. Now, since we are dealing with traumatic subluxation, we know that the patient will give you a history of trauma. Sometimes it may be so trivial that he just, got up, bumped his head, and he may not even realize that he had a problem until a few weeks later. But you can get few subtle signs on clinical examination. So you could see pseudophacodonosis. You may see that the iridolenticular gap is more. You can ask him to look on either side, maybe on lateral gaze. You may see that the bag equator is seen very well. There could be focal iridodonosis, but then you may also see such a frank dislocation right into the vitreous, or you could just see some haptic into the anterior chamber. Whatever may be the cause of how the traumatic subluxation has happened, there are certain principles of management that we can follow which will guide you as to how to treat a case. So in the initial, when the patient first presents to you, you have to do a good, complete clinical examination. That includes history. If the patient already has had pseudoexfoliation, you may see some flaky dandruff material, then you know you're expecting that this can be a pre-existing zonular dehiscence, and now that trivial trauma has just caused a further dislocation. You need to know what is the type of trauma. If it was something small, limited to the subluxation of the lens back complex, then you're okay. Otherwise, it becomes a sort of combined approach with your vitreous surgeon and vitreoretinal surgeon, because there could be vitreous hemorrhage, ciliary body dialysis, and so many other problems that could be a part of it. So a good gonioscopy can help you understand how the angle is, do a B scan or a UBM, and then assess for the clock hours of break. We need to know, can we fix the same? Can we use another lens? Presence of vitreous will tell you whether you do an anterior or posterior approach. And then, of course, the most important, whether are you going to use the same lens or would you like to exchange it? Today, I'm going to show you 3 cases where we have done some way of management for that eye, but most of the cases that we have approached till today, we've had to use only these surgical instruments and tools. And I think if everybody have these simple tools in their OT, you're fit to be a surgeon who can treat these traumatic subluxations. So now the first case was of a patient who unfortunately also had a few clock hours of subluxation to begin with, and hence we had put a Sionese modified capsular tension ring in his primary surgery. And he came a few months later, probably I think few years later, saying that he had a trivial trauma, and the suture that was taken through that CTR had broken. So now we were in a position to refix that same CTR. So here we are using a 90 Prolene with a straight needle. We have done a conjunctival flap. We've gone from the sclera, looped it through that hole, gotten the suture out, and then threaded it back onto the sclera and fixed it. Here, since along with the trauma, there was a little bit of mydriasis, so we also used the single pass 4-throw technique for pupilloplasty. And you can see that in the end, the patient had very good vision. Or rather, the postoperative outcome was exactly how he had before the trauma. The next case is of a patient who, after a trauma, he hit his head while getting up, and after the next day that he got up, he said that he can't really see very well. And when we examined him, we found that part of his lens back complex was subluxated anteriorly into the anterior chamber. On dilatation, we found that the rest of the zonules were fairly stable. Now, this is something of importance that if it is not a case of pseudoexfoliation or Marfan's or any pre-existing zonular pathology, most of the other zonules are pretty strong. Only the part which may have subluxated is something that you need to look out for. Since the bag was fairly fibrosed, we decided to do a belt loop sort of a suture just around the haptic that had come out or broken. So we just tucked the lens back into its original area, and then we used again a 90 Prolene with straight needles, and here we are using a 26 gauge needle 2 millimeters behind the limbus. We have tracked it from the sclera behind the iris on top of the lens first. We have railroaded the suture out, and then the next loop goes under the haptic and through the sclera out. In the end, once you are looking at the 3 reflections, Purkinje images on the cornea, you will then tighten the suture depending on where you want to pull it and fix it. So this is a fairly good way where if there is no vitreous disturbance, you have really gotten away with doing just a minimal intervention. And this is the image of the patient on first post-op day. The third and the last video that I'm going to show was very recent. He's just come to us last week. Probably he knew we are coming for AIOS, and he came with a trauma. There were some people having a fight, and he just wanted to stop them from fighting. And in that process, he himself got a nasal blow. And this is the lens that has come out nasally, anteriorly subluxated, the entire lens back complex. Now, as you can see, that this is a multifocal lens. Now we cannot think of probably taking it out because the other eye is also enjoying a very good vision of 6/6 N6. So now our plan here was that we will plan and refix this entire bag lens complex onto the sclera again. In this case, we have used the AIOS anchor with a with NRI diamond blade. We have just made a incision, and now a Hoffman's pocket will be created, or rather was done, with a 1.25 millimeter keratome. As you can see, there is very minimal vitreous displacement over here. The posterior capsule was incidentally opened up post-yak capsulotomy, but the anterior capsule was quite intact. So a 26 gauge needle was used. We insinuated a little bit of space, put high molecular weight viscoelastic to make that space even larger. Now we are using capsular hooks to just stabilize the bag while we then go and introduce the AIOS anchor to suture this entire lens bag complex onto the sclera. That Hoffman's pocket is a very good way of suturing or keeping the sutures buried. You could also do a conjunctival flap, but this is a little more patient-friendly approach. So now we are planning to go through the Hoffman pocket. Again, a 90 Prolene with straight needle is used. First, the direction should be towards the posterior pole, and then maybe you can use another instrument like a spatula to redirect it so that it comes just above the entire lens back complex, and then you railroad it out either using a forceps, but what we use is like a visco cannula which has a slightly thicker opening, so then it can very easily come through that. You can also do it with a 26 gauge needle, but maybe sometimes the dexterity of putting a smaller thing into a smaller one is not so easy, so a visco cannula really does the trick very well. So once one loop is out, we use that same needle to then track through the AIOS anchor, and then the same needle can go back in. So here you don't even need to use both the double ends of the straight 90 Prolene suture. So now from the other side of the sclera, we are using a 26 gauge needle. Again, the same path, posterior pole directing, and then just lifting the iris up and coming behind the iris, but in front of the lens back complex. And then the same needle has looped and tracked out through the sclera. So now is more the kind of the tricky part, but I think it's quite challenging and fun, is that now you have to hook the AIOS anchor onto the anterior capsule. And as you can see, the AIOS anchor has a T-shaped end, which kind of goes under the anterior capsule and it holds it. The rest of it is flush to the sclera, and you can pull it according to however you want the tightening of the bag. So in this case, there was very minimal vitreous disturbance, but you could still put a little bit of triamcinolone and look out for if there is any kind of vitreous. Then the sutures need to be tightened. So here we have put a little bit of pilocarpine, gotten the pupil down, and then taken the suture out from the Hoffman pocket and then tied it. Here you could use a light pipe to just for a better visualization, since that area is under the Hoffman pocket and it may not be so clear. But once this tightening is done, the sutures are very well buried and the patient really does not feel anything on the first post-op day. So cases like these can also get an excellent outcome without even requiring to use your vitrectomy machine, but that's not the message. You have to look out for the most minimal the things that you can do which will give you a good outcome. So my take-home messages will be that there will be lens back complications that you will encounter, considering we are off late seeing a lot of dead bag syndromes as well. So we need to be prepared. On this podium today, we have seen a lot of different ways of making sure that we can fix the lens onto the bag. But we have to remember that it is a tailored approach. Each eye will behave differently, will come with a different set of trauma, and we have to accordingly manage. But careful management can definitely result in a good visual rehabilitation. Thank you so much.
Thank you, Dr. Tanvi. Fantastic presentation as usual. I'll just take 8 minutes. Again, 4 interesting cases, only a video presentation. Audio nahi hai. Audio.
Let's discuss 4 interesting cases. Case number 1 is a non-dilating pupil and a subluxated 3-piece IOL. In such a scenario, rings do not play any role due to limited exposure, so hooks have to be placed. It's important to make 4 guiding marks for the hooks and then place the hooks to get adequate exposure. Now there's a trick here. If you want to refix the subluxated 3-piece IOL, you need to make sure that it is well centered. To center that, the best way would be to mark the center on the visual axis with a Rexis marker. This will help us as a guideline to center the 3-piece IOL which is subluxated in the sulcus. Now how do we make sure that this 3-piece IOL never subluxates or dislocates again? The best way would be to make an opening in the fused anterior-posterior capsule with the help of the vitrectomy probe. Once that is done, we can capture this optic into the opening, which is what is being done now. So the inferior optic margin is captured first in the opening of the fused capsule, and now the superior margin is also captured. By this technique, the lens will never ever subluxate and ensures perfect fixation. The second case is even more interesting. It's a subluxated multifocal IOL with a YAG opening. This patient insists on multifocality. Patient was allergic to phenylephrine. Under topical anesthesia, we injected intracameral mydriatics. Triamcinolone acetate guided anterior vitrectomy is done for vitreous which has come through the YAG opening. The optic of the IOL freely rotates and we are sure that there is no vitreous entrapment. The catch here is to explant the optic disc. It's very important to hold with a micro-grasping forceps, use a micro scissors, use the incision as the fulcrum and then rotate the optic out of the incision. Once that is done, we make sure that the freely floating haptic is also removed, followed by vitrectomy in the pre-existing YAG opening to make sure that there is no vitreous. A 3-piece multifocal IOL is loaded and implanted in the sulcus, but we have to make sure that this multifocal IOL does not decenter, dislocate or subluxate. The only way to do this, of course, is to do an optic capture in the YAG opening. We now have a well-centered multifocal IOL which will never decenter again. Case 3 is even more interesting. A subluxated back complex with an endocapsular ring. Patient gives a very interesting history that when he sits he cannot see, but when he lies down he can. So we decided it is possible to refix this back complex, created 2 Hoffman pockets on both sides. Once that is done, we decided to fixate the same point equidistant from the optic-haptic junction on both sides and do a railroad technique. The first pass is from below the endocapsular ring and the haptic, and the second pass is from above the endocapsular ring and haptic. Then both strings are brought out and tightened. Once that is done, a similar technique is employed for the opposite side. Equidistant points are selected and railroaded. The first pass will go below the optic-haptic junction and the endocapsular ring, and the second pass goes from above. One can now see how beautifully this whole back complex easily centers on the visual axis. We can achieve good centration by refixing the same back complex which had actually subluxated. Case 4 is even more interesting, where there is a dislocated IOL. There is no sticker from the patient. B-scan obviously showed an IOL, but the design is unknown. What are our options? Explant the IOL, glue a new IOL, or do a posterior iris fixation. We started doing vitrectomy, and to our luck and surprise, the lens started floating up. With a micro-grasping forceps, we make sure that we grasp the lens and don't let it fall back and get it back in the anterior chamber. Interesting to note here is that these are non-foldable 6.5mm optic IOLs with dialing holes. Notice the orientation of the haptic. The plan was to glue this IOL, but in this orientation it cannot be glued. The only way out is to flip the IOL in the anterior chamber to get the orientation and angulation of the haptic correct. These lenses have a 10-degree forward angulation, so it is important to orient them in the right plane. One can see that through two 0.75mm incisions, we have now flipped the IOL in the anterior chamber, got the orientation correct. We have already made two scleral flaps on two sides so that we can externalize these haptics. This is a non-foldable 3-piece IOL with stiff haptics. So one has to be very careful in externalizing these rigid haptics because they can break when we are trying to externalize them. After externalizing the rigid haptics from the scleral tunnel, the next step, of course, is to tuck this IOL and glue it. We tuck the IOL under the scleral flap with a 26-gauge needle, and finally, we glue the original dislocated IOL in position. So through two 0.75mm side ports, the original IOL could be refitted and well centered. In conclusion, whether it is a subluxated IOL or subluxated multifocal IOL or a subluxated bag complex with ECR or a dislocated IOL, we should be ready to refix it, replace it, resupport it, or flip it and refix it. Principles to follow are: in case of a non-dilating pupil, it is best to use hooks for adequate exposure. Mark as per the corneal reflex to ensure adequate centration for fixation, and capture the optic to ensure permanent fixation so that it never decenters. For a subluxated multifocal IOL, principles to follow are: use of intracameral mydriatic agents, triamcinolone acetate guided anterior vitrectomy, proper instrumentation for explanting IOL, and knowing the principles of optic capture in the bag complex for a 3-piece multifocal IOL. In case of subluxated bag complex, principles to follow are: to refix the bag complex, point of fixation should be equidistant between both optic haptic junctions to successfully refix the bag complex. For dislocated IOLs, anterior vitrectomy is done to free the IOL, orientation and angulation of haptics is corrected by flipping the IOL, refit the original 3-piece IOL. Thus, complex cases have good visual outcomes when handled with care.
Thank you.
Thank you very much, Dr. Kumar. It certainly was a complete exposition of the entire techniques. And thank you very much, Tanvi, for your talk. That was really very nice. I still remember when we first started doing intraocular implants, one of my leading surgeons had turned around and said, "Tell your patients, herogiri nahi karna, koi ho to bhag jana," which is one of the ways to, I think, prevent having another problem occurring with these lenses. And thank you so much for being with us. I hope you enjoyed the course, and I hope All India will continue giving us this opportunity in future. Thank you so much, everyone.